And I think we'll begin with Donna Kinzer, pardon me.
Good morning. Thank you very much to Kaiser Permanente and the Kaiser Foundation for inviting me here today to talk about a little bit about what we're doing in Maryland and to reflect on the wonderful remarks from Dr. Burston, very provocative questions, and to share some of the initial observations and efforts that we're taking on in telehealth in Maryland. And I have one slide, and I have one disclosure. My disclosure is I'm the executive director of the Health Services Cost Review Commission, and we're implementing a payment and delivery model transformation. And so, of course, that colors my view of the world. And I appreciate the opportunity to tell you briefly about what you're doing and then to delve into some of Dr. Burston's provocative questions. So I just wanted to give you a little background on what we're doing. I have only one slide, so I'm not going to spend a lot of time in the slide mode. But I think it's important to just set a context to understand what I think is that everybody keeps bringing up is the reimbursement challenge, and how we're tackling that, but also some of the elements of that make it more difficult to tackle than we might imagine on the surface. In Maryland, the reimbursement system is moving away from a volume-based model, and since 2014, hospitals in Maryland have been paid on a budget that is set at the beginning of the year. Our system is driven off of a per capita approach with value-based payment, and the system covers all 6 million Marylanders. The budgets cover hospital payments for all payers. And this is being brought forward through provider-led efforts. This is not a big government project. We're implementing this with our commission, which is 7 voluntary commissioners and 37 staff. So obviously, we're not implementing the transformation that is taking place. It's the provider community that is implementing. And we're doing this under a federal demonstration that allows Maryland to set hospital payment levels for all payers. And Maryland has been setting hospital rates for all payers since 1977 under federal waivers. But in this situation, we moved away from a rate-setting concept really to a per capita concept in 2014. And just to give you a little view of what we've been experiencing, we have been experiencing savings to the Medicare program without cost shifting. And we've had some very significant reductions in avoidable utilization. We've been able to stabilize rural hospitals in Maryland through this model, and I'll talk a little bit more about that, which of course is a big national concern. When we started this program, we were among I can't say this proudly, but we were among the highest states in readmission levels for the Medicare program, and we have now reduced down to the national average, even though we have many social problems, particularly in our urban areas. And so we've been doing this since 2014, and we're currently in the process of designing a program to take us forward that will go beyond hospitals. And we see a little circle, a set of bubbles in the slide. And so now we're operating the hospital per capita program, with some care redesign programs that are provider initiated. As we go into 2019 and beyond, we will be on a per capita program for total Part A and Part B cost for about 800,000 Medicare beneficiaries in the state. This is the program that we're working on and designing now. And as part of that, we will launch a primary care program, part of which will allow telehealth and other non-face-to-face visit activities. We will also be focused on driving population health efforts that are aligned with the model, particularly opioid and diabetes are the first two that are of top interest to Maryland as we move forward. And we're trying to do this in, we don't have the fully integrated delivery system, and we actually are trying to do this in a virtually integrated delivery system where we use alignment approaches to align providers across the delivery system. And so as a result of that, we're expecting to have improved complex and chronic care and population health, as well as increased alignment across the system. So that's just really a brief view, just to try to set the stage of what we're trying to accomplish in Maryland. And so I just wanted to talk a little bit about some of the things that hospitals, since they are the first participants, have been trying to cope with and to do in the new system, particularly with telehealth support. As you think about this from a hospital perspective on a per capita budget, so the hospital's questions are, how do we afford the new treatments and the new technology? And how can we free up some money to help us address this, some of the population health and social determinants of care and care management needs? And so, so that's been what hospitals have been working on in this first 4 years of the Maryland model. And in that, they've been focusing on reducing unnecessary emergency room visits and avoidable admissions so that they can free up money to afford care management and new treatments. And so some of this is leading to work with emergency room providers and nursing homes. So I'll get into that in a minute. And also the growing mental health crisis is an area where Maryland is relying on telehealth to move forward its efforts. And finally, I think as we move, as I mentioned before, as we move into the second phase, Maryland will be bringing telemedicine into the primary care environment. And the rural health environment is the final area where we're seeing an increase in the telemedicine activities, combining rotating physicians into rural communities with telemedicine and trying to bring more care back into the rural communities as opposed to necessarily take more rural patients into urban settings. So I just want to step back a few minutes and tell you a little bit about some of the emergency applications and some initial observations and some continuing problems and challenges that we're going to be tackling on an ongoing basis. We have been working in the emergency, the MEMS, our emergency medical system transport, that transports patients to the emergency room, has been working to, in some demonstrations, to determine what percentage of patients need to go to a hospital emergency room versus who could actually be treated in the home or in an alternative urgent care type of setting, or the next day at the doctor's office. And we have 7 demonstrations underway with this, and the statistics that have come back from this so far are that more than 60% of the patients don't need to go to an emergency room. So, to some people, this is not new news. This is old news, but now we have a system where the providers are becoming aligned to want to make sure that the patients get the treatment in the right setting, at the right place, at the right time. There are some challenges to this, though, even though we have hospitals who are now aligned in this methodology in terms of wanting to make sure that the patients are getting the treatment in the right place. The emergency medical system only gets paid if they transport the patient to the hospital. So this is a problem for the emergency medical system. So we haven't solved that problem yet, but I think we're on the way. And so that's an example of what we're doing, and the challenges that we still face. And I just wanted to briefly talk about the nursing home environment, and then I'll turn over to our next speaker. But our hospitals are connecting with long-term care facilities to try to provide specialty consults to avoid unnecessary transport to the hospital and unnecessary admission. So those are a couple things that we're tackling in Maryland, and some of the problems that we're still experiencing with reimbursement. So thank you very much, and I'll turn over to our next person.
We can turn it over to Brian.